Hi, this is Joe Hage. I lead the medical devices group on LinkedIn, which is the world's largest medical device community. I'm here today broadcasting live for WBBA-TV, and I have the privilege of interviewing Chair and CEO of OtoNexus Medical Technologies, Caitlin Cameron.
Thank
Welcome.
you. Thank you.
Now, I have a little story to tell our studio audience and all of you in TV land. Caitlin was not originally scheduled to appear on this broadcast, but after I heard her presentation, I came straight here and I said, you have got to get Caitlin on. So no pressure at all. I want you to help the audience understand why I'm so excited about what you're doing. Please tell us, what is the problem you were looking to solve?
Sure. So OtoNexus Medical Technologies was founded by an ENT, Dr. George Gates, who spent 40 years treating kids with a variety of ear problems, but particularly otitis media, and was very frustrated with the fact that in the world, otitis media is a disease that affects so many children, and in fact, we do such a poor job of both its diagnosis and its treatment.
Now that's a big word, otitis media. What is it more commonly known as?
Middle ear infections.
I have a middle ear infection.
Middle ear infections in kids. Adults get middle ear infections as well, but this is primarily about kids. So otitis media, or middle ear infections, is the #1 reason for antibiotics in kids. It's the #1 reason for surgery in kids. And the last time anybody cared enough in this space to do a full study to really understand the cost was more than 20 years ago. And at that time, it cost us about $5 billion a year in the United States alone. And we believe that number is probably 12 to 13 billion today. We're not sure. But clinical studies show that doctors get it wrong about 50% of the time. That is to say, they're pretty good at diagnosing no infection or infection, but it's very, very difficult with today's technology to differentiate the difference between a viral or bacterial, primarily viral, primarily bacterial, and in particular when and when not an antibiotic is appropriate. This device specifically is designed to make that key differentiation. It uses Doppler ultrasound in a completely novel way in order to give the diagnostician the key data that they need to differentiate between antibiotic and no antibiotic.
So I'm going to paraphrase what I think you said, make sure I got it right. Middle ear infection is the #1 cause of children going to the doctor. Is that true?
#1 cause of children going to the doctor is actually upper respiratory infection, common cold. This is #2.
Okay, fair enough. I was close.
You were close.
And 50% of the time that there is a middle ear infection, doctors will get it right. The binary question of, do they have a middle ear infection or not?
What they will be, so doctors are pretty good at determining that there's no infection. What is very difficult with today's technology is differentiating between an infection that requires an antibiotic and an infection that does not.
Okay.
Primarily viral, primarily bacterial.
And the tool they use today is what?
It's usually an otoscope.
Which is how old?
It's been around for more than 80 years.
And hasn't been innovated on
since it was invented 80 years ago.
Okay. Yeah. Now, having seen a prototype of your device, it looks a bit like an otoscope to my naked eye.
Yeah.
But it's different because you did what?
Well, so it looks a lot like an otoscope intentionally because our goal is to create a device that is very easy for a pediatrician or other clinician to pick up and just incorporate into their practice. Doesn't add any time. It's exactly the same sets of steps. But the key difference, of course, is that we've incorporated our Doppler technology, Doppler ultrasound technology. You, just like an otoscope, you look in the ear. It's got basically a digital otoscope capability to look inside the ear and blow up that image. But you press a button, you get an ultrasound reading. That ultrasound reading in particular measures the viscosity of the fluid behind the eardrum or the tympanic membrane. And that viscosity translates directly to what kind of infection and how to treat it. So in just a second or two, the physician is given the definitive and objective data that's required for the instant and accurate diagnosis of otitis media, and in particular, the key differentiation to know absolutely antibiotic or no antibiotic.
The reason I got so excited by your presentation was, as I understand it, there is presently no effective tool on the market anywhere in the world to help with this diagnosis.
That's right.
And despite the fact that it looks an awful lot like an otoscope, don't be deceived because there's a lot of really hard technology in there.
Yeah, exactly.
Can you give us a sense of kind of what that evolution was? What is it about this technology that before OtoNexus focused its energy on this project that none of your predecessors got here? What is that concept?
Yeah. So in particular, so Dr. Gates, again, as an eminent researcher in otitis media, tried lots of different technologies and lots of different things over his career. And it wasn't until he was here in Seattle, the ultrasound capital of the world, that he said, hey, let's try ultrasound. Our technique uses Doppler ultrasound, but in a unique way, in that we shoot through air. We do not use gel for a gel coupling. You know, if you go in for an ultrasound to the doctor, they'll put gel on your skin, it's gel coupling. But you really don't want to fill a kid's ear with gel and dig it back out when you're done. So we've developed an absolutely unique ultrasound transducer designed for Doppler measurement through air. And so we ping off of the eardrum, absolutely non-invasive, completely non-invasive, and get a very, very accurate reading of what's going on the other side of the eardrum. You're really looking for kind of 4 states, even though it's a continuum, sort of think of a 0 to 100 continuum. Air, which means no infection. So if you have ear pain, you have something else. You have TMJ or you have allergies or some other thing. And then you've got a viscosity of fluid that's indicative of primarily a viral infection, a much thicker viscosity of fluid that's indicative of primarily a bacterial infection. And if it goes all the way to the end, you get what's technically called glue ear. And that's when, in fact, the child needs surgery, needs the tubes put in the ear to help drain. And it's actually a continuum. You can watch the infection progress and you can watch it resolve. One of the things the physicians tell us they love about this is you can watch what's happening in the resolution and whether in fact it is resolving the way you want it to. And it's an instant read, so you can watch these data points over time.
So to recap, recognizing it's a continuum, there's air, bacteria, viral, or glue. Mm-hmm. Tell me about the difference between bacterial and viral, because I think that's where a lot of the more complexity is, because it's fluid, but you're able to discern what kind of fluid.
Yeah.
How, through an ultrasound, can you do that?
Yeah, so what we're doing is just building on exactly what happens today. If the child is sent to a specialist, they'll usually use a tool called a tympanometer. And a tympanometer uses air to move the tympanic membrane or the eardrum and uses that measurement to say, is there air behind it or is there fluid behind it? And that tool, which is used not in primary care generally, but is often used in a specialist's office, does a pretty good job of saying there's fluid. But it cannot tell the difference between what kind of fluid.
And it's expensive.
And it's expensive.
Painful.
And it's painful for the
and
child
you get
if they haven't.
child.
Yeah, exactly. Think about that.
Nobody likes that.
Nobody likes that.
Trust me.
Yeah. So we're building on that technology, similarly the technology of the pneumatic otoscope, which are both designed to try to measure what's going on in terms of fluid behind the eardrum inside the middle ear by watching the movement of the tympanic membrane. The difference is we use Doppler ultrasound, which is so exquisitely sensitive that it can detect minute differences in the viscosity of that fluid on the other side of the eardrum based on how the tympanic membrane or eardrum reacts
So is it fair
with what's
to say
going
that
on.
Less viscosity equals one or the other, bacterial versus viral?
Yeah, yeah. So it's actually air. Thin viscous fluid is going to be primarily viral, and I say primarily because there are always some combination of both, but primarily viral. It gets thick, almost honey-like, and you have primarily bacterial, and then almost solid in order to get to glue ear.
Okay.
And you can just watch that continuum go up and down. One of those key elements is we are building on these things that the physicians have been doing for a very long time. So they already understand and know that this exists. We're just taking it to new technology, and in particular, the key differentiation that's never been made before is, they can pretty well tell usually that there's an infection, but not tell do give an antibiotic or don't give an antibiotic. And that's so important now, is all of this technology, everything we've got is pointed at we need to reduce unnecessary antibiotics, and otitis media or middle ear infections are a key area for massive overprescription of antibiotics.
Now, just for those who may not know, and frankly myself included, what are the effects or some of the most deleterious effects on children who are taking unnecessary antibiotics? I mean, what's the cost to the family and to healthcare?
Yeah. You've got a couple of things going on. First of all, you've got obviously the societal impact of all of these antibiotics and getting these resistant organisms in society. And that's why everybody is so focused in general on reducing antibiotics. But on the child as well, you almost always have the side effects of diarrhea, nausea, all of these other terrible things. But also in particular, a buildup of antibiotics early can actually create a situation where you're encouraging more ear infections later. And what we understand now from the CDC is they're telling us that if an antibiotic is given too early in even a early stage bacterial infection, it suppresses the child's immune system. So the child never builds up the antibodies that are necessary for the child's own immune system to battle that bacteria. And so by suppressing the immune system, you're actually predisposing that poor child to the next ear infection and the next and the next and the next and the next. So by appropriately deciding when to give an antibiotic, you're allowing the child's natural immune system to respond. Now, there are times that it's absolutely appropriate to give an antibiotic, and this system, our device, will help tell the physician
Can you give me a
precisely when.
sense of, so out of 100% of ear exams or middle ear exams, and with perfect information, what percent will you find air versus bacteria versus viral versus glue? Do you know that?
What I do know is this, is the experts again from the CDC telling us that we are providing antibiotics in approximately 85% of cases for otitis media or middle ear infections. We should be providing an antibiotic in just 25%. That's a big gap.
So is that delta the sum of the glue ear plus the viral that shouldn't get an antibiotic? I want to understand.
It's simply the total number of cases of all of the cases. The problem is that it's hard to tell exactly the answer to your question because it's hard to tell. When a physician or a pediatrician, anybody uses an otoscope and does a visual inspection, this is how it works.
Yes.
The child comes in to the pediatrician, they do a visual inspection of the outside of the tympanic membrane or the eardrum, and they're attempting to guess what's going on the other side. And they make a guess, and they treat based on their best knowledge. Some are pretty good, and certainly, again, they're pretty good at deciding no infection or infection, but very difficult to tell viral, no antibiotic, bacterial, antibiotic, and even some stages in between where there's still some differentiation to be made.